Okay, so keep eating. There's a lot of good food and desserts, and I'm just going to talk anyway. Again, I want to encourage you to ask questions that you're thinking about. Somebody just said to me, I had this question, I didn't know if it was the right time. It is the right time, because if you're thinking a particular question, I promise you 5 to 10 other people are thinking the same question, okay? So jump right in. It'll make things a little bit more lively, and you know, having listened to myself talk a lot, I get boring after a while, and you all liven it up. It's just way more fun. So please jump in and ask questions. Yeah? Sure.
When is enough? So
okay. Yeah. With a medical issue. So, what can you repeat? Did you put a jacket on? You changed your appearance. Okay, so yes, she asked, when is enough enough, and gave the example of health anxiety. And when you're getting ready to get surgery or to choose a doctor from a specialty area, how many doctors should you see before you make a decision? And I think that's very interesting. So, number one, okay, we're assuming that they have an actual medical condition. Now, hopefully, this will make you smile and stop a little bit. I say 2. 2. That's what a second opinion is about. 2. Now, somebody might say, well, what if the first 2 were terrible? And I know when you get estimates for like getting your house painted or moving across the country or whatever, you get estimates from 3. But having moved a lot, 3 is always 1 too many. They start to sound alike. Now, all joking aside, 2. My hunch is, they will still feel anxious and they'll want to get a third person, but then they're looking for reassurance, and then they have more choices and they're going to obsess, and then it becomes they cannot choose and commit for possibly a medical procedure that they need to have done. Now, is anybody here going to be honest and react to that and say, well, what if? Because then I want to hear that, because then I can explain a little bit better. Anybody?
what if they get
What if one is different than the other? In exact opposite of the other?
Then probably you are going to decide to take the person who agrees with what you wanted to do in the first place. I mean, I hate to say that, but that's what I think. Now, I mean, think about it. I have heard countless stories of people with OCD, and there's this fellow who is really quite good with ERP work in very severe OCD cases on the North Shore, north of Boston. And many, many cases, they went and they saw him once. He said, we need to do exposure and response prevention. It is going to make you anxious. You're going to have to do some things that you don't like to do, and we're going to stop these things. And everybody saw him once. And then they went and saw somebody who told them what they wanted to hear. Oh, we're going to talk about your feelings. I think we have to see why this started. And I always say to my people, why doesn't matter. I'm a little off topic, so I'll finish up with you in a second, but why doesn't matter. Why you're getting a particular obsession? Oh, I guess it's fun if we figure it out. Then we go, woohoo, I got to figure it out where it came from. But that is not an excuse to avoid or not do ERP. It's an explanation, and who cares? Even when you understand beautifully. I had someone who, one of my first cases ever, she accidentally suffocated, when she was a preschooler, she suffocated a parrot, a family parrot. Put her in it, wanted to carry it around and pet it, so put it in a shoebox with a blanket around it and carried it around with the top down all day because the parrot wanted to get out. Well, the parrot died, it was suffocated, and then the person who already had OCD developed harm by neglect obsessions that were really quite bad. So yes, we understand why she had that particular obsession and why it was difficult, but it didn't matter. So the medical thing, I suppose, if it is life-threatening, then you go for the bigger hospital. There's a joke. Okay, that you go, okay, and maybe if you're looking at two people who talk about alternative treatments, then I would go, well, I need to talk to somebody who's going to do the standard operating procedures, right? But with medical things, remember, yes, let's do a little bit of reassurance here. There are standard procedures for appendectomies. You take it out. You close the person up, right? Somebody who wants to have you have a gluten-free diet, that's a little bit different. So if you're not hearing what's normally done, yeah, I guess I'd go talk to somebody else. But if you have OCD and health anxiety, guess what you don't do, which you've all done? Okay, let's fess up. How many people look up things on WebMD? Everybody, hands up. And how helpful was it? It wasn't. It made it worse. And not only do you now have, now you have more than an earache.
Right.
You need to have your ear removed, the same as Van Gogh did. Looking things up, and whether you have OCD or not, I actually think that's true. Someone as a gift gave me, and this is the old days, the Mayo Clinic Family Medical Resource. It's this big fat book, and there's tons of colored pictures. Well, I just opened it up, and I said, okay, this gift is going in the trash. I do not want to see the photos of the worst possible case out there. It made me uptight. And I certainly didn't diagnose correctly. When you are, we're a little, I'm a little bit on health anxiety, but I always tease my health anxiety patients, where did you get your doctor degree, your medical degree? What's the matter, you? And how do you know better than the doctor does? Because, think about health anxiety. Health anxiety, remember, hypochondriasis is still a separate diagnosis, and but I think the health anxiety OCD model really works for a lot of the health anxiety. You go to the doctor, you're help seeking, and then you reject the advice they give you. No, I can't take that medication because that medication has side effects. Then you go to the next doctor, and I can't do what you're telling me to do, and then you go to the next doctor. Why did you go to the doctor? Because you're anxious. Did anybody feel frustrated with me saying 2? Oh, great. 2. When we have people with scrupulosity and we're consulting with their rabbi or their priest to help them get on board with treatment, we say you get to check with 1 priest. 1. Not 2. Not the web. 1. Because if you can always find someone who will agree with what your worry is. Okay, if you have more questions, jump in though. Okay, it probably triggered people. Thought-action fusion. I love thought-action fusion. Thought-action fusion, there's like 2 meanings. The thought is as bad as the action. And again, not to slam Catholicism, but they have the lovely one that I can remember off the top of my head where something like I'm not Catholic, my husband is. Thou shall not covet your neighbor's wife. You're not supposed to be looking through the window with binoculars at your neighbor's wife, even when she's in a swimming suit, right? Okay, and if you are looking, that's a sin. Now, it's actually more complicated than that. It's like, don't go, there's no place like home kind of deal, something like that. Dorothy, somebody said it. All right, so, but the thought is as bad as the action. Now, if you think about that, if you're worried about pedophilia, thinking about molesting a child is as bad as molesting a child. And a lot of times people with those obsessions come to the unit and they tell me they're going to kill themselves rather than molest a child. That they're going to be dead before they hurt a child. So it's pretty serious. But what I do is I have them kind of go like this, and I'm like, okay, the thought of molesting child versus molesting child, which one? Which one what camp do you want to be in? I would rather have a thought than actually hurt a child. So, yeah.
It was Christ that said, when you look at a woman, you've already committed adultery with her in your heart.
Yeah.
So for him, the thought and the action were one and the same thing.
Yes.
And, CBTers, the only thing I don't like about the CBTers is they never, I don't know why they can't include behavior in the title of their theory. Why can't they have, call it, BC, behavior, rather emotional cognitive behavior therapy. Like
Yeah.
they discount
Yeah.
they discount the feeling. Because oftentimes feelings fuel thoughts.
Yes,
And
absolutely.
it's the energy behind the thought.
Yes.
And then you don't always take action. You can have a whole array of thoughts and a whole array of emotions and
Right.
still not act.
Yes.
And then you can act without thinking or feeling.
Yes. That you just act
Psychopath.
impulsively. Yes. Excellent point. Yes. And a lot of times talking about it doesn't have a big impact. It's changing the behavior. But okay, the second one is having the thought increases the likelihood that the event will occur. So in my group, there's this big whiteboard, and every time everyone comes into the group, they write their main obsession, their harm, or their sexual obsession on the board. And each week they try to make it that they're leaning into it a little bit more. So what they're doing is they might come in and initially say, I'm having a thought that I could stab my mom with a knife. Okay? Or no, let me change that. I could stab someone with a knife. Okay? It's very, very vague. And then I have them say it out loud. Now, you could do this with your individual patients. Start as soon as they get past the intake, that every time they come in, they sit down, and the first thing they do even before you start talking is they write out the main thought, and that each week they're moving towards saying it more explicitly. So someone is really vague. Or it even could be not even stab with a knife. They could say, I could hurt someone. And that's what they start with. Okay, fine. The next week is, I'm having a thought that I could stab someone with a knife. The next week or the next couple of weeks, depending on how they go, they can go, I could stab my mom with a knife. I could stab my mom with the kitchen knife that's a cow killer because it's really, really big. And my mom, Anne, is going to die because I'm stabbing her. And each week, it's moving towards the thought in a way that becomes more and more triggering, but it also allows them to, one, work on reducing shame, and two, hitting at they're doing a mini exposure to get ready to do exposures, but they also can work on the thought-action fusion. Having the thought increases the likelihood the event will occur. So what I do with that is I write on the board, I say, okay, let's try this out. And what I often do in group, or when I'm doing the educational piece, I talk about something that's more removed from their obsession, and then I bring it back to their obsession. So we go, okay, let's see what we can write. I'm going to write on the board, Carol will die in a fiery car crash en route 2 tonight on the way home from work. Okay? And then everyone in the group, I've got some people doing this thing, and some people are going like this, and they're kind of lost in thought, and then I'm like, no, okay. What do you think about the thought? And people will say a range of things, and they'll say, you're tempting fate. This is bad karma, Carol. You shouldn't have said that. Is that what you were thinking?
Just an interesting anecdote. A number of years ago at one of these conferences, Jonathan Grayson was here.
Yeah.
And he said, we're going to do an exercise. I'll ask you all to write down just the words, I wish, and then the name of somebody you love. So we all did it, and we're all smiling.
Yeah.
He said, everybody have that? We said, yes. And then he said, now we're going to finish the sentence. We'll die a painful, horrible death. And I saw half of the clinicians in the room threw their pens up in the air and said, haven't you heard about the evil eye? Started arguing with them. Now, many of them were clinicians who could not do that.
Yes. Well, and remember, we have a cultural thing going where for those of you who have elderly parents, if you listen to your friends talking, my mom's really sick, I'm thinking about, when she dies, then I want that one painting. And then they go, I shouldn't have said that, right? Because we don't talk that way, especially about someone who is sick or elderly. We're not supposed to do that because we all get into this thing that's like bad luck, which is superstition. Now, let's go back to killing me off on Route 2. So we write it on the board, and then I have someone say it out loud. I'll say, who can say it out loud? And then people will say, some will say, I'm not gonna read that out loud because then I would be responsible if you died tonight, right? So, and then somebody who's a little further along in treatment, they'll go, Carol will die in a fiery crash on Route 2 going to Talbot's because that's where she always goes, or something like that. That's a joke, guys. But then we talk about it. Okay, so what if I died that night in a car crash? Was it because we wrote it on the board?
No.
Would anybody worry that it was because we wrote it on the board? You would worry, yeah. And so we got to struggle with that a little bit. I guess it's possible that because we wrote it on the board, that then we tempted fate, or maybe that made me drive recklessly. I don't know. But does it really connect it? And then we got to test it out. So everyone commits to not ritualizing at all about it. And then I stay in my office all morning. And they have to sit a little bit with, okay, they don't know what happened to me. And that maybe they will feel responsible. And then we change it up. The next week we, yeah.
Oh, sorry. I just wanted to say that what you said about reading the thing on the board and about dying on Route 2, I think that's why it's important also as a society for us to move away from, the superstitious, almost like religious things that can sometimes turn into obsessions for types of people like, us or in this room. And I just think that adds another dynamic to, the OCD and then other things that make people anxious. And I just think it's my opinion that we should be more humanist and sort of just whatever, makes us better and makes our anxiety go down and is what we should be doing more so than, things that are going to do the opposite.
Right, like worrying about, I can't say that stuff out loud, which is exactly why we have you say this stuff out loud.
Or worrying about being sacrilegious for some reason.
Right, right. Yeah, and it's a fine line because certainly there are certain settings in which you want to be more respectful. Someone was talking to me during the break about, being in my groups in the old days and saying, you were a lot rougher on us, in the group. And I said, well, that's a little bit, it's different because I have to tone it down a little bit for a broader audience who I don't know. because I have to say I'm terribly irreverent about a whole bunch of topics in the group. But then we're working on it, whereas this is like one trial learning. But I've got, right now, this is actually true. This is not fake news. So my daughter and my husband are in the air right now, coming back from Oklahoma. So what does it mean if I say it is possible that they're on Southwest, and that the Southwest plane could crash coming into Logan and end up in the water, because that's a weird airport right in the water, right? It's possible that that could happen. They're going to die today, sometime before I'm done with my talk. Now everybody's What are some of your automatic thoughts about my saying that? Well, she's awfully cheery. She probably wants it to happen. What are you going to say? Why would I say that? Matt?
Just words in your mouth.
Okay, they're just words. Somebody else.
Just magical thinking.
Okay, yeah, that I would be that powerful. Somebody else? Did I see another? Yeah,
Just that you're courageous to say that.
yeah.
If it does happen, you're going to feel so guilty.
I think people think they have more power than one of my psychiatrists, my therapist used to tell me that you don't have any more power
Yes.
than,
Yeah.
because
Yes.
you know what, OCD patients, we think that we have so much power,
Yes.
and we don't,
You're
just by
absolutely.
saying words.
You are absolutely correct. Yeah.
So I have a question.
Yes.
Sort of about what this gentleman is asking you, and that is, when you're faced with something like this, what's the balance between giving some kind of a reasonable answer versus not feeding into the obsession at all by either just saying, it could be, or maybe it actually will, and getting into the details. At what point do you make that shift if you're a therapist or if you're a family member in terms of responding to something like that?
When do you give an answer?
Well, I'm talking about, you can give lots of answers. You can give the answer which this gentleman talked about, which is sort of like a reassurance, a logical, rational
Yes.
way for them not to worry,
Yes.
versus
Yes.
not playing into the OCD at all and giving that kind of challenging, either, like you said before, like it could just happen, or even maybe it really will happen.
Yes.
How would it happen? So when do you know when to do one versus the other?
That's an excellent question. Now, what I do is, it depends, my answer is going to frustrate some of you, it depends where they are in treatment. If they are further along in treatment, I am going to err towards giving them less reassurance regardless of what's going on. If it is earlier in treatment, I'm going to explain some and say, okay, I explained it. If you ask me again, I'm going to say, okay, we already talked about that. But there's something in the middle, too, for family members, and that is when someone gets reassurance from some event that happened in the family or in a conversation, you can always re-trigger, which is very, very helpful. So if someone says, Carol, your husband and daughter are going to be fine, Southwest isn't going to have, say I have OCD, Southwest isn't going to crash, and then I go, phew. I always can re-trigger and say, well, what do they know? I have no way of knowing what, nobody did the BAL for that pilot before they went, and I hear the Boston traffic controllers are kind of out there too and really into pot now that that's legalized, or whatever. I can say something to take me back and put it with the uncertainty. Do you have anything to...
Well, I mean, you're saying how you can get re-triggered, but my focus of my question was really, how do you respond? What is someone supposed to say? Because we get those kind of questions a lot. What is too much? What is too fast? What's too intense? I don't want to be part of the OCD system, and reassure them because that's part of what it's looking for, and that just feeds the whole, circle, the dynamic. So, even when, I find that when we first have families come in and we're educating the parents about what they need to be doing differently, there's always the sense of, but, you want to pull the reins in so they don't kind of just blast their kids,
Right.
to the point that they can't handle it.
Okay, I would say it depends developmentally on the age of the child. And so if the child's younger, there's going to be a softer way in which they set some limits around the verbal reassurance. I also have like a list of questions or ways of responding that the family can choose from, because I don't want the parents to get too rigid in their response, that they really have to be flexible. What would Carol say? If she were sitting here right now, what would she be saying back to you? And then the person provides the answer and blocks the reassurance themselves. She's going to say, this is great. She's going to say, we don't know.
In other words, what would your therapist say?
Yes, well, I'm sorry, yes, what would your therapist say? Once they really are rolling in therapy, they know what it is that you would tell them in the moment. If this was happening in the therapy session, even the little kids, they know exactly what you're going to say. And if they go, or they're not going to give themselves reassurance if they're being honest. They're gonna say, Dr. Wegg would say this to me. I think you can say, I don't know, to a lot of it, because that's the reality. And maybe I'm kind of hard-nosed about it because I've done the work for so long, or people are so desperate by the time they get to our unit that we got to play hardball. Part of what I see is, it's harder for the family than it is for me. And I always talk about that as the love factor. When it's somebody who you love and they're so anxious and they're in tears and they're trying, doing a little emotional blackmail to get what they need from you, it's very hard to say, I don't know. You're going to have to wait. Something bad might happen. But that's really the reality. And my experience is most people tolerate that pretty well. And if they aren't tolerating it, maybe they need to make a call to the therapist, and then the therapist can help them decide.
So what I'm hearing you saying is that on that continuum, it's better to risk giving them less
Yes.
than...
Think about it. You give them less. You can always give them more if you have to.
Yeah.
But then if everything starts coming unglued. Okay, what I say to people when they're working self-directed, and I guess you can think about this with the parent mode too, is when I say I want you to jump this high with your homework, your exposure homework, and the person says, I can't do that, then I go, okay, what can you do to move forward towards it? If you can't make it here, I might have said her a case earlier where she did great. She's had a baby. She went off medication, so she's very symptomatic with harm obsessions now and is working on doing a lot of intensive ERPs about the new obsessions. But she's very avoidant right now. And that's very overwhelming and maddening for her because before she went everywhere. So what I said was, something about Target is really terrifying for her. And I said, Target's off limits. You don't go to Target, no matter what. You don't go to Target. Now that's paradoxical because if she goes to Target, it's great, right? But I said, oh no, you can't go to Target. That's too hard. But then I said, where can you go? And then she said, oh, I got the baby dressed and I got myself dressed and then I chickened out at the door. Okay, well, could you go put her in the car seat and turn the ignition on and then turn it off and take her out of the car? If she does that, that's a win. So I don't have to get, ideally what I want. What I need for them is to push on the OCD and feel empowered in doing so. Because Rome wasn't built in a day, people. This is hard work. And some days, for whatever reason, you can't do what you set out to do. You got to remove judgment. Okay, this is what I did. What could I do instead? How can I move forward? That's probably a crappy answer, though. Go ahead.
I was just going to go back to Alan's question about, what's the right thing to say as parents. I think what you said too about being in the right developmental level is
Yes.
crucial. I had a 7-year-old girl who I was working with doing exposures in the school setting, but I'm sorry. I had a 7-year-old child I was working with in a school setting, trying to do exposures with her. However, the main issue was getting her to school. So if the parent did not provide the reassurance, is anything going to happen to me, she couldn't get her to school.
Yes.
So you have to consider those kind of what's first priority
Yes.
in that situation, I feel.
Yeah, you've got to, first thing, you've got to get her to school, or you're not going to be able to do the exposures.
Right.
So when I've had cases like that, I have to shore up mom's defenses. Mom takes the clothes, puts them in a bag, and sends them to school in their PJs. And the social pressure from that they got to go and change at school, usually clears that up like in a week. So, yeah.
Yeah, and also developmentally, obviously, the older the child is, the more they can handle. So
Yes,
teaching them to
yes.
cope first. you
Yes.
know, with,
And sometimes with young children, it's all about stimulus control. They're really too young to do a lot, but the parents can do things like limit the amount of soap that's in the bathroom, limit the, the amount of towels that they can use or paper towels that they can use, block the answering questions if they can. So, and that may be where they are for a while until the child gets on board. Yeah.
Sometimes I think what works also is if I'm dealing with the child and the parents fill out the family accommodation scale.
Yes.
So then I explain, we go over it, and then the child says to the parents, this is what I think is okay for you to pull back on. Like, because we're not going to do all 10 at the same time.
Yeah.
So that way the child feels some control and empowerment that, I'm talking to my parents about what I think I can handle.
Yes.
And then we go week by week and we start to gradually increase it.
Yeah. Yeah.
I have a question on superstition. Like, what if the superstition feels like OCD? Like, what do you do?
If the superstition feels like OCD,
Yeah, or what if your OCD thought is kind of like a superstition? Like, how do you know what to do?
okay, so,
Could you repeat the question?
oh, yeah, I can. So if something's a superstition, what should she do? Should she treat it like it's OCD? And I think it's great, you're worried and you got to throw salt over your shoulder. Well, why not do an experiment? And then when that happens where you get triggered and you feel like I should throw salt over my shoulder, try to not do it and then just see. What's your automatic thought when I say that?
To get nervous.
Oh, fabulous. Okay, good. So we're hitting pay dirt, right?
Which she can't hear. Which she said.
Oh, she said she said she'd get nervous about throwing the salt over the shoulders. Okay. So that she may not do that experiment right away. Even talking about, maybe not throwing the salt over the shoulder is a really good start. Oh, okay, so the next time I have this, I can think about or imagine what it would be like to not throw salt over the shoulder. Now, if you're doing that and you wait, maybe you could delay, which is a really good strategy. Maybe I can wait to throw the salt over my shoulder for 10 minutes. All I have to do is wait for 10. Now at 10 minutes you can say, it's a little easier. Maybe I'm going to wait a little longer. Or you can say, no, now the whole shaker's going to go over the shoulder. And that's okay too, right? But that you're thinking about it and trying to wait, that's a good way to start. Somebody else have their hand up? Yeah.
How do you treat someone who is completely resistant to acknowledging that they have OCD? I'm working with a 13-year-old girl
Right.
in home,
Yeah.
and she's religious. She's Orthodox
Yeah.
Jewish, and she's got lots of scrupulosity plus contamination fears. But just bringing up the words, or even if I try to talk about other kids with symptoms and try to kind of trick her into talking about symptoms, she literally freaks out. So I think one of her obsessions is labeling herself. If she says she has OCD,
Yeah.
she has OCD. So I literally can't, it's so hard to do any psychoeducation because she will not go there. She's visibly terrified.
Okay, so what she was asking about is what do you do when you have a child, can be an adult too, who doesn't want to call this OCD and doesn't want to work on what they need to work
Or
on.
even talk about the symptoms.
Not even talk about the symptoms. Okay, well, you have a choice point. But with a child, I'd be looking at, okay, is there anybody else in the family system who's on board that this is a problem? Whether it's mom, whether it's dad, and then maybe they're the ones you're working with for what you can do to limit some of the ritualistic behavior. And the other thing is to teach the family not to walk on eggshells. We certainly have had people where there was big long lists of words that couldn't be said in that house, and the whole family was going along with it. So all they have to do, as easy as it, as it isn't, is to start to use the words not on purpose, but when that word comes up in conversation, that they don't purposely avoid it. And then there's this, this experience, and on the one level, the child starts to learn on some level that the catastrophe didn't happen, and that they can tolerate these spikes of anxiety, and they're kind of surviving, or maybe they say, oh, maybe this means they'll be more motivated to get help. So there is a lot that you can do with the parents ahead of time. The 13-year-old just isn't ready. So the other thing is there's a lot of reassurance in OCD and conversation and in visual cues. And so the family or the partners can do a lot without any help from the sufferer at all, just not going along with it. I would like to go to the evil meter if we can try to find it. So, because I'm just going to jump around a little bit here. So the evil meter is something that I do that I find very helpful. And I do this quite regularly. You can do it individually. Speaking of shame and the guilt, okay? Because it's always really pretty bad. And I love to do this in a group. The power of the group is phenomenal, but you can do it individually. You could also do it with families. So what I do is I write on the board. I don't try to talk them out of it, remember. We write on the board, we have 0 evil. Those people are the good ones, okay? I don't put those names up. Those are just as an example. And then the 100% evil, we got the bad ones. Not that I'm judging, right? Then I ask the person or the group members to give me some really bad people for whatever it means. We're really good at coming up with the bad people. Idi Amin is a dictator from one of those countries, or he used to be. Sometimes Hitler goes up there. Sometimes we have serial killers, many of whom are from my home state of Wisconsin, by the way, something for Wisconsin to be proud of, because we had Ed Gein, we had Jeffrey Dahmer. Jeffrey Dahmer was actually psychotic, but that's another story. But Ed Gein, the guy who murdered people and made upholstery out of the, he recovered his furniture with skin. Yeah, he was in Marionette, Wisconsin. Yeah, he was up with the bad end. So judgmental. So we get some of those up there, right? And then we go to the good guys. So a lot of times it's Mother Teresa, Gandhi's usually up there, Martin Luther King Jr. One time somebody said George W. Bush. There's nothing wrong with that. That was very cute. And it varied, and I was tired of Mother Teresa. She'd been up there too many times. So we get the ends anchored. And then we just look at it for a while. A lot of what I do with this is I just sit there and I look. And I go, okay, do we got anybody else up we want up there? And we talk about it, we laugh some. And then we go around the room and I'll say, where are you on this scale? When you think about your intrusive thought, how evil do you feel? Okay? And then we write on the board where they are. And a lot of the people in the group are way up here with Edie. Okay? They're way up here. Then we got some smart alecky people who are down here, and they say, oh, I'm 20% evil. And I'm like, why are you at the OCDI? You don't need to be here. But most of them will be up above 50. Okay, we write their names. So, John is 70, Jean is 95, blah, blah, blah. And some people will put themselves at 100% evil. So we put all of those up there, and then we look at that a little bit, and we ponder it. And then I go, okay, let's, where should we put the person who is a carjacker, okay? Now, these are all people with OCD. And nobody dies, but they stole a car with somebody else in the car, so they had to shove them out. Where should we put them? And then somebody inevitably raises their hand and they go, well, it depends. Do they have a weapon? Is it loaded? And they'll come up with 10 clarification questions that they need answered. And I'm like, okay, this is all I'm giving you. They're a carjacker. And they'll go, oh, they're like 30 or they're like 20 or whatever. And then I go, okay, what about someone who physically assaults someone else? And then we put that up there. White collar crime, okay. And then murderer. And then we put a pile of these people up there. And frankly, what inevitably happens is it's much more scattered. So we got all the OCD people up here with Idi Amin. And then we got all these people who actually did something that wasn't so great, and they're everywhere on there. And then we look at it, and then I open it up. I do not tell them what I want them to come up with. I say, what do you guys think? And inevitably people will say, well, she shouldn't be up there at 80 because she's not a bad person. And she's certainly not like a murderer. You should be, what's your name?
Debbie.
Debbie should be down here at 40, which is really kind of like high, right? What did Debbie do? But whatever. Okay. And so they start to tell me where everybody else should do. And then we go around and we say, do you want to change your number or do you want to keep it the same? And then what really comes up is that people go, you know what? I didn't think of it this way. I didn't think about this. I think I should be here. And a lot of times there's this change where they make themselves less evil. And you actually can see them feeling a little bit of relief. Now, we just talk about it and then we just go on with our day and they go to dinner and I go home. And you know, it's changed. It goes back to the original number later on in the evening, right? But there's this brief shift where they can choose to look at themselves and how they view themselves, where there's a little bit of a break. It's a very powerful exercise. And it also gives me a foot in the door to start to talk about compassion and the double standard of OCD, where they have one set of compassionate rules for everybody else. Everybody in that group has compassion for the other sufferers and does not see them as a bad person. In fact, they think they're wonderful and they're lifelong friends. But for themselves, they really struggle with letting go of that. Another strategy that we use is we have them say to a friend, it's like the old Gestalt technique. The younger people think it's something new, but it's really like the old Gestalt technique. So what would you say to your friend if they were feeling this way? Okay, and so they say what they would say, and they've got the scenario, and then we take a mirror and we put it in front of them, and then they have to say the same thing to themselves around the context of having OCD. That's very powerful also. Usually ends up with a lot of affect, but it helps them to experience that they really aren't cutting themselves any slack. Questions? Yes?
Just a comment, I've used this technique also to draw the difference between thought-action fusion.
Yes.
Where do you put somebody who thinks about stabbing their child versus where do you put somebody who actually does stab their child? So they can really see the difference between where those two people would line up.
I could do that. I haven't done, that's a great idea. I haven't done that. One is because I didn't think of it, so.
Well, I didn't really think of it. I think I got it from a book.
But I'm going to copy it next Thursday, so I'll have to get your name so I can give you credit for it. I think I would worry, but as a therapist, I would go, okay, I have to be ready for they're getting stuck with I'm the same as the person who stabbed them. So it depends on how entrenched the thought-action fusion is, because I don't want them walking away feeling like, okay, now, and somebody's going to do this. Carol thinks I'm really bad, I'm 90% bad because we said that the mom who stabs her child is X. So that would be my only worry. But we gotta try these experiments. There's no bad experiment, it's just more data. Okay, so let's see. Let me talk about disgust a little bit, and then I want to talk, oh, well, you know what, I'm gonna come back to that. I wanna make sure I get to the important things. Okay, harm and behavioral urges. Does everybody know what a behavioral urge is? So some of your people with OCD will say that they are sure they're going to act on something, and that's the evidence that they're a bad person, right? So if they're thinking about driving the car, they feel like they're going to turn the wheel towards the thing, that they're actually going to do it. It's called a behavioral urge, right? And that's very, very scary. And they use that as evidence that, they use that as evidence that they're a bad person, okay? They feel like they're going to push a person. They feel like they're going to grab a knife. So why are they doing that? Do I have a psychopath and I haven't diagnosed them correctly? And my feeling is no, although we never know, right? And that is, think back to the old days. Anybody swim in public pools? So in the old days, when I was a child, they would blow the whistle and pick up the megaphone and they would shout, "Don't run." All child therapists know what I'm going to say. Don't run. And what did all of those little kids do? They started to run faster before they slowed down. Just like the pink elephant. Don't think about the pink elephant. You must think about the actual thing before you can think about don't. So all the kids at the pool ran faster before they slowed down. Now, because people are smarter now, they blow the whistle, they pick up the megaphone, and they shout, "Walk." And the kids slow down faster. So if you're saying, don't do this, don't push this person, don't push this person, you actually are thinking about push. And it's, how do we get out of a chair? We have a behavioral urge and we get out of the chair. It's something very, very similar. So again, I know I'm doing a lot of educate them, but that's a lot about what you have to do to decrease shame. Is let them know they aren't crazy and then re-trigger them. So behavioral urges. I had a case where the woman was worried she was going to stab her boyfriend while he slept. So he came in, they were delightful, they were so cute. And we went from a smaller knife to a bigger knife. I call the bigger knives cow killers. So she had the knife and he was sitting right there. And we're doing the exposure. And then she had the behavioral urge to go forward with the knife, okay? And just was so overwhelmed. So I said, okay, let's go for it. I want you to move the knife like you feel like moving the knife. And of course she cried and cried and cried, and the boyfriend kind of smiled. Probably hoped I knew what I was doing. And what she did was, and of course she was very upset. She went like this with the knife, very triggering. And then she moved it back. And then that evolved into the next step of her exposure. So for the next few weeks when she was doing the exposure, she would periodically move her arm. So one, it was very triggering. Two, over time, she started to realize, okay, the catastrophe doesn't happen, even though I'm acting on this behavioral urge. Because it wasn't actually hitting him above the sternum, right? Because you got to hit him above the sternum, otherwise you just a bone, just so you know. Okay. So, and then she came in a little bit later, and she was a good patient. She came in and she said, okay, I need to now stop doing this, because it's now functioning as reassurance. Because every time I do this, I'm like, hey, I didn't knife him. This is cool. So then she had to move towards not doing it and going back to the original exposure of just holding the knife. You follow the obsessions in the exposure. Where do they go? So I'm often saying to people, as we're doing the exposure and at the end of the exposure, what's your automatic thought about this? Because that's going to give me the hint for where we have to go next. I don't want them to edit, because otherwise they're just going to tell me like what the perfect ERP is going to be. I don't care about that. That's not helpful, and that's not going to help them. They have to tell me what's going on in their head. So we follow it to the end. Okay, let's go to the next one, because I want to talk about sexual responsiveness. This one's even trickier. With the people with sexual obsessions, a lot of times, and I'm sorry, but yes, clinicians, you have to tell them. Sometimes they are going to respond sexually to the obsession, and that is terrifying for them. Terrifying. And I promise you, for the most part, they haven't told you. Because that's the proof that they really need to be locked up. So you have to talk about it. Now, you don't have to talk about it like I do. You don't want to copy my style. You want to make it your own so you can feel comfortable with what you're doing. Otherwise, it's just like talking to your children about sex. You're going to screw it up, right? You got to make it, it has to be you. It has to be genuine. The brain is your largest sex organ. And if you focus on something, you are going to respond. And sometimes I give the example, I'm sorry, I think you've heard this one before. So, go back to your high school years. And the boy asked you, or the boy asked the girl to go on the date on Friday, and it's Monday or Tuesday. You guys, weren't you ever teenagers? You're thinking about whatever sexual. Now I'm not even talking about sex. I'm talking about sitting close to them, maybe holding hands, kissing, and they're really hot, right? You're thinking about it for 4 days. You are ready to go on Friday night. It's going to be a good time. And part of that is sexual responsiveness. Why? Because you were thinking about it. The same thing happens with the obsessions, except it's intertwined with a bunch of yucky feelings, okay? So you gotta say, yes, you might respond. And then you can even be more graphic, because otherwise they think, oh, you meant liking the thought or whatever. There may be some enjoyment to the thought, as repulsive and disgusting as that is. But then they use that as evidence, and I look at it differently. I go, this is a good exposure. We are going to do an exposure about this. Now, the other thing that I do, too, is that I know they're not ready to do a particular exposure, but I mention it. I do this in groups all the time, where I go, oh, well, that's going to be a good exposure for you. They just had a moment where they start to fantasize and plan, yeah, I'm going to do that exposure at some point. I can't do it now. But that's all an approach strategy, because really what we're trying to get is we're moving them from, I can't think that thought, I don't want to do this exposure. We really want to move them towards, this is great. This is the opportunity of a lifetime. I can really get better if I start to do this. Now, getting better is not getting rid of the thoughts. Getting better is changing the reaction, so their response is more neutral. Yeah?
Is it important to differentiate between a fetish and a sexual obsession? And if so, how does it alter the treatment?
Oh, like if it's a fetish and if it's, okay.
Versus
so, yes. Let me just think for a second. Okay, so when you are pairing sexual arousal with a particular object, right? Let's use some of the basics. Shoes, right? Haven't you guys ever watched going to the movies and stuff? Okay, shoes. How did that happen? Well, when there was sexual arousal, there were shoes present, right? Then they can't get aroused unless they have the shoes present, or someone wearing a particular lingerie, and then they have trouble getting aroused when that is absent. So then I believe you're using covert sensitization, so you're trying to break the connection and then have them like masturbate to a more appropriate object or thought or image that is more like age appropriate or appropriate for the setting or whatever. We end up doing that sometimes at the unit, not in a group setting obviously, but we have a lot of exposures that are like that. Yeah.
I want to follow up on something you talked about earlier, which is when the exposure exercise becomes itself a form of reassurance.
Yes.
Talking about the sexual stuff, where a person will fantasize or look at some stimuli that's a little bit more intense than even what, let's say the homosexual stuff. And so they begin to think about the homosexual stuff or looking at homosexual stuff, and then they find, well, that really doesn't bother me. But now they look a lot because by looking, they're kind of checking and seeing that they're really okay.
Right, so there's a couple of things that I do. One is I predict that at the front door, and then they forget about it. But, I say, okay, this is going to be changing, so what was a great exposure here is going to turn into more of a ritualistic checking, and then we're going to cut it out. So, so that they start to understand what's happening. And really the bottom line is anything you are doing or thinking or saying can become ritualistic when it becomes more inflexible and when the function of the behavior, thought, or whatever is to try and to lower your anxiety. So it is very possible that something is going to morph into checking. And so then we have to follow the obsession, if you will, and say, okay, now your exposure is, you'd really like to check and see if you're attracted to so-and-so, but now we're gonna block all of that. You can't go and watch those videos. You can't go and watch that TV series. You're gonna just stop that and you're gonna, say, write scripts about wherever their worry is. Yeah.
What if the person that you're working with, like say your child, doesn't make the connection that it's providing reassurance to them? So they might just come in and say, I'm doing the exposures, I'm doing it, and nothing's getting better. It's almost kind of tough for the therapist then to kind of identify that. And should that be something that should be they should be educated on before even doing the exposures?
Usually, and the other thing is there are certain normal phenomena that happen with learning that I predict and teach, and I teach the correct words. With kids, I'll modify it. So, and then I'll get you because I saw your hand up several times. So I always teach about extinction bursts. What's an extinction burst? You don't have to remember this, people, unless you've got the GREs in a couple of weeks. Then remember it. So last question. Okay, extinction burst is when you like start the ERP, you're really opening the floodgates. So the thoughts and the urge to ritualize are going to increase briefly. Briefly is relative, I don't know how long it's going to go, before it starts to die down. So when they say to me the exposure isn't working, we look at what's happening and then I go, oh, this is great. And I make a little chart and I say, this is what is happening to your obsessions. They are screaming at you. The OCD is having a temper tantrum. And what it wants you to do is give in and ritualize. And then, if there are parents, I'm going to talk about temper tantrum. I mean, I want to find examples that are relevant for that person and that they're going to understand. Where they actually have seen an extinction burst, because I'm sure they have, and then they go, oh, it's just like that. So it's like I'm giving them kind of an educational framework on which to hang their experience. Now, that's outside the ERP. I'm not in the exposure saying, this is an extinction burst, don't feel bad because it's an extinction burst, because that's not helpful. But outside the ERP, we go, yeah, that's happening. Same with spontaneous recovery, which is, okay, stuff's quieted down, and then they come in 3 months later, and the old obsession is back. Suddenly contamination is an issue again. Well, that's probably because they weren't doing kind of a maintenance ERP for the contamination. It pops back up. Instead of going, this is terrible, you're backsliding, we can't help you. Okay, we got to say, oh, this is spontaneous recovery. Of course it comes back. This is going to happen. This means that learning's going according to plan. The other thing is, remember how we used to think, this is for the older people, that we used to think that old learning was lost, and now we know that there's old learning and there's new learning, but the old learning can pop up at any time. That's how our brains work. So a lot of what the person with OCD, how they view treatment as not working, is actually that it's working fine. And I want to share that with them to keep them motivated. We know that exposures work. Really what treatment is keeping them motivated to do what they need to do. Yeah.
I apologize because I asked a question just a couple of minutes ago, but I'm
sorry.
looking, we only have like 20 minutes left, and there's a lot of great slides that I'd love you to talk about.
Okay, which ones would you like to see?
Well, there's a whole bunch at the end that have to do with very specific interventions.
Yeah.
Oh, okay, let's go to those. Let's see. Okay. Do you want me to, let me talk about imaginal exposures just for a minute and the shame-based exposures. Okay, so whenever you find it is no big deal.
Yep.
She's
There you
wonderful.
go.
I'll have you this cut for her at the end. Okay, imaginal exposures. I do it, it used to be that we wrote big long scripts, but I found that to be, with some of our people at the unit, the motivation was a problem because they got very overwhelmed and then felt very sad and no longer felt anxious, which actually wasn't bad. But I thought, okay, I have to keep them willing and motivated to do the treatment. So I started breaking it down to smaller sizes, and that works great. Remember what exposure is. We're boring the brain. Our brain likes to be entertained. So we pick trigger words. So it might be Satan, 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 Satan. Now, we do 4 hours of exposure a day, 2 hours are coached in theory, it's what we're hoping for, and 2 hours are self-directed. If you are writing the word Satan, one is your hand is going to get tired. 2, if you're saying that out loud, you're going to get bored. And then after a while, you just don't care about Satan anymore. And it usually happens within that first day of that word. And then what happens is the roles are reversed. They're coming in, they're begging me to do something harder. Carol, I can't write that word anymore. I just can't do it. It's really stupid. It's not bothering me anymore. So they're complaining that we aren't working fast enough. Yes. So then we go to the next word, devil, 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 same thing. Then we move to a sentence. It's possible that I could become a disciple of Satan, okay? And then they write that. That has more meaning, that's more triggering. But they only write that sentence. Then we vary the grammar. It's possible. It could happen. It might. It will. It should. It's probable. All of those things increase or decrease the anxiety. The only thing to watch for, clinicians, is that some of your people need to go to the point that they do an exposure where they say, I am a pedophile. Some of the other people, that won't work because it isn't I am. Then they're like, I'm not anxious because I'm 100% certain. So that exposure doesn't work because that's not where their obsession goes. They have to go to, I could be, I will never know. Most of the time, I get enough bang for my buck these days by having them sit with the idea of, I will never know. Whether it's sexual identity, whether it's that someone will accidentally be killed on their watch. Now, you know what I always say to them is they're like, well, you always act so brave, but if that really happened, it would be terrible for you. And they're absolutely correct. If my husband and daughter die in that Southwest plane today, that will be one of the most devastating events of my life. But it hasn't happened, and so I'm choosing to not be upset about it, nor do I think there's any connection with just saying it. I'm not that powerful. I'm not that powerful. I can't jinx the plane. So, and again, then I go to the long script, like what you saw in some of the old treatment books. Lots of detail, smells, visual cues, auditory clues. Get more specific, details with the names. You can just write it, you can read it silently. Usually reading it out loud or having a coach read it is going to bring things up, but don't assume you know where the obsession is going, you must ask. Okay, because sometimes, a lot of times when they write these scripts, if they read it in public, or like in a hallway, yeah, they're uptight, but are they uptight for the reason that I want them to be uptight about? Or are they uptight because they're worried janitorial staff is coming by? And they, do you know what I'm saying? That it's social anxiety and you know, appropriate norms versus where their obsession is. That's the important piece with that. The other thing is to mix the imaginal exposure with something that's real. So it might be that they're doing this and props, knives, photos. Often I have them bring in photos. If I can't get the brother or sister or aunt or dog into the session, we can use photos. We can now do the FaceTime thing, okay? So as long as the patient's in the room with you, we can do it like that. We can use movies. We can do driving ERPs. We can bring in children. All of the children of the OCDI staff are used all the time for exposures. Now what's interesting is people in, from like, my kid's been in the exposures from 6-year-old on to being 18. Okay, so yeah, we have kids with diapers, and you know, then everybody uses that as an excuse for why, you know, their partner's pregnant again. Because, well, we needed more babies, so they gotta get on it. So animals. We now have quite a few therapy dogs most of the time. We also have therapy cats, and for a while we had therapy rats, which I used on myself, frankly. But they're really quite cute. But we don't have the rats now, but we do have the cats and the dogs, and there's been birds and there's been bunnies in my office. It all makes it real. And even if nothing much happens while the animal or person is in the room, afterwards they can always write a script. So we have people going out in the van every day. The mall is wonderful for exposures, as are just regular strip malls. They are going to be discreet in public about their worry, but then they can come back and write a script. Yeah?
When we talk about the imaginal ERP, do you try to focus more on the uncertainty, the anxiety that the uncertainty provokes, or both? Because, you know, even people without OCD can get very anxious before, like if you're talking about stabbing, but is that really attacking the OCD?
I
mean,
do
like
a
when
lot.
you talk about smells, I mean, are you talking about...
That's for the longer scripts, and I do a lot less of that than I did in the past. I really go for the uncertainty. That usually that does the trick. And remember, we're not actually having gore, so to speak. It's that we're triggering the worry connected with the gore. Yeah.
You're doing the exposure to desensitize them to the anxiety? That's the
Well,
goal, right?
what you're doing,
So that you're
okay, so
desensitizing.
we on purpose trigger the worry, and then, which the person has had happen millions of times before. That isn't what's going to get them better. What's going to get them better is they're changing their reaction.
And they're getting bored to the same
Right.
things. That's triggering off.
Right,
the
we're
anxiety.
extinguishing the response. So, I think I'm gonna answer this better in just a second. I want to go to the mental rituals, if we can find them. So we already talked about that. Okay. One of the, have people heard of pure obsessionals?
No.
Okay, even Wikipedia has a section with pure obsessionals. So we used to think about pure obsessionals at the unit when I was first hired there, and now we think of it differently, and I think the way we think about it helps us to help teach everybody how to block the mental rituals, because those are a booger. They're in your head. We can't see them. You can't see them. They're just there, and they're very automatic. But so the With the pure obsessions, the worry is the same as the compulsion. There's the initial trigger, and then there is the thinking about the obsession in order to figure it out, to let it go. And we think of it as that's the function of figuring it out is your ritual. So, can we go to the next one? Okay, so one is the person has to periodically talk back to themselves and say, I'm not going to be able to figure this out. Even if I think I've got it, I still don't know 100% for sure. So that's the re-triggering. The other thing is what we're doing more now is integrating more ACT, acceptance and commitment therapy, and shifting attention to another task. Which, so the goal-directed tasks helps people with OCD to be less symptomatic. So we trigger the worry, and then they help with lunch prep. And they have to keep going, they can't stop. And if they still are ruminating about the original obsession, we might have them narrate and describe what they're doing. Okay, now I'm getting coached by Tim, and I'm cutting up peppers for the salad. This one's a red pepper, blah, 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 blah. And that they keep talking to themselves about what it is that they're actually doing, and that helps to cut down on the mental rituals. The other thing is outside of the exposure that they work on being mindful and being present. And we can do that with a sport, throwing a ball or a frisbee back and forth, by a guided mindful walk. They can work on it self-directed with some of the wonderful apps that they're learning to practice for brief moments of time to be more present. Because remember, with your obsession, you are somewhere else. You're either in the past or the future or whatever, okay? You're not in the present. Again with this, going back to I will never know. We can go to the next one. Let's see. What else can I be telling? I want to say something about inhibitory learning and the research that's getting publicized more and how helpful that is. So remember, inhibitory learning is the main thing. So that's when, with exposures, that's when you get triggered and then you move on with your day. You get triggered and you can't do an exposure in the moment because often you can't, but you go to work and you do the best you can. And maybe your day is kind of difficult and you keep going back to the obsession, but you do the best you can at doing whatever it is that you can do. When you do that repeatedly, there are goodies with that also. So if you do an exposure and you don't get habituation, it's not all lost. You learn over and over and over again the corrective information that the catastrophe didn't happen the way you imagined it. Might have been a sucky day, but nobody died. That's very important. You need to learn that repeatedly. And the other thing, you learn what we all already knew about you, and that is you can tolerate much more negative affect than you thought you could. A lot of what you're doing in the OCD loop is avoiding the anxiety. But if you think about, like, when someone dies in your family, I don't know why I'm talking about death so much, but when somebody dies in your family, you understand that you are sad and you're tearful and you reminisce and you do whatever rituals your culture goes along with. But then you go back to work or you go back to school and you understand that you are still going to be sad, that it isn't going to go away in the 3 days that they gave you off from work, right? That this is going to be an ongoing process. So you live your life and you take your kids to school and you pick them up from school, and meanwhile at the same time you feel sad. And you're working on accepting that this is the way this is. Now that's kind of a grim example to give, but it's one that most of you understand and have had some experience with. That's what we're trying to do with some of the anxiety, is that some days you are going to be discombobulated and worried, and you need to go on with your day. And you will be able to do more than you thought. You had a question before, and then you got put on hold.
Thank you so much. I'll try to be quick. But you've answered a lot of what I was thinking about, but I just last week had someone come in, this is going back to the sexual obsession, and he insisted that he needed his wife to come in for the first session.
Okay.
And it turned out that he had OCD that had been pretty much dormant in remission for about 20 years. And it was triggered by watching a news story about someone, about a rape. And so he's ruminating about this incident when he was in college and was out drunk with some friends, and there was an older woman who came into the bar and wanted to sleep with all of them. And so he went out to the car and had sex with her, but now he's replaying it in his mind that it was rape. And so I was, it was just the first session, but I was trying to get to a behavioral component to work with.
Yeah.
So I wanted to ask you about just the balance between how you might balance some of the imaginal exposure or this shame-based ERPs and any kind of behavior. He did say he's avoiding news stories about violence and rape, and so I just wanted to get your perspective on
So, that's a great question, and we have had a couple of cases like this where it's something that happened in the past and then the person gets really, really, really stuck on it in a very obsessional way. And with those cases, I'd have to hear more details, but in those cases that are actually going pretty well, there was one where the husband was thinking about something that the wife had done prior to being in a relationship with him, and he couldn't let it go, and it was decimating the marriage. We used more of the act and the mindfulness and in the shifting attention than we did in the exposures. The exposures were limited to like writing the fellow's name, certain verbal words that were avoided, and I may be thinking about this for the rest of my life, which is often what it is when it's a past event, because there is the event, but then there's something about the torture of, I will never be able to let this go. And then that's where I'm really pushing the focus of the script. But I will say, I would probably stay more with the radical acceptance, and he's never going to know for sure, and shifting attention, and see if you can get some traction.
And so you wouldn't go at all at the same time to try some exposure?
My exposure would be that he doesn't know what it was. So that's where my focus would be, versus that he actually raped someone.
So even like scripting? This
Yeah,
may
that.
have happened, or?
One is, here's the deal. Often with these cases, whatever it was that they did, they come in and they insist that they did something, okay? And as we get to know them better, it's really the OCD went wild with it.
He knows he didn't. He knows he didn't.
Okay, so, yeah.
About the relationship, building the relationship and getting to know where he is.
Yeah, I'm just a little bit more careful before I dive in, so I do something easier with that till I get a better sense. Yeah?
Do you ever train them to say forward what you already know? Because all the answers are in the formula. All the answers are there.
Yeah.
Most people with OCD know the answers. They're
Remember,
coming
they
in,
can't use
it's
logic.
the reassurance that they
Yeah.
constantly need. And giving them more reassurance, they become addicted to that. They need more reassurance. And that's the problem. They gotta be their own therapist. They gotta go
Yes.
with what they already know.
Yes. Yes. Okay, all right. Thank you. Is there any questions? Yeah.
Can you talk briefly about number rituals and number obsessions? You haven't touched
Yeah.
on.
We really
Oh.
have to wrap up.
Okay, we have to stop So you can email me, my email's on there, and I can answer in a little more detail. Thank you so much.